Thank you to Esther and thank you to the organizers for inviting me. I'm going to give a rationale for the use of these therapies in septic shock. So I'm going to discuss endotoxin and on organ crosstalk. When we talk about sepsis, we are talking about an old concept. This concept was described many years ago, saying that some patients do not die from infection, they die from the host response to infection. And this concept is quite stable during the years because in the last definition, sepsis was defined as a dysregulated host response to infection. So the concept is the same, just change a little bit the clinical criteria for diagnosing sepsis, which, as you know, is suspicion of infection and organ dysfunction measured as 2 points change in SOFA score. So this immune host response to infection is similar to other conditions that go again with systemic inflammation. So the insult could be the infection, but other conditions like major trauma, pancreatitis, etc. But the triggers are quite common, are the DAMs and PAMs. PAMs, the most important one is endotoxin. It's coming from the pathogens. And DAMs, or alarmins, are coming from the host. Endotoxin, as I said, is the most important one. It's the major component of the cell wall of the gram-negative bacteria. And those triggers, DAMs and PAMs, are being recognized by the host cells, immune cells, by the PRRs. The most important one are the toll-like receptors. So in this cartoon, you have this recognition. This recognition in the inactive toll-like receptor 4 of endotoxin, and this leads an activation of toll-like receptor 4. This activation activates the nuclear factor kappa beta, which is able to regulate the transcription of the genes that codify for the cytokines, with the release of the cytokines and the systemic inflammation. So again, you have this here, you have the endotoxin, the macrophage and the immune cells, the toll-like receptor, and the cascade of phenomena that take place after this recognition. In the middle, you have the pro-inflammatory response. On the right, you have the neuroendocrine response with the production of catecholamines, increase in oxygen consumption and increase in oxygen delivery. And on the left, you have the activation of the coagulation. On the upper part of the slide, you have how the anti-inflammatory cytokines are counteracting in this activation of the inflammatory response. I have to say here that this reaction is adaptative. We should treat these patients. It's not always good to try to immunomodulate patients in the ICU because in some situations like this one, this situation is completely adaptative and those patients do not need treatment. However, we said that some patients have a dysregulated host response, those patients with sepsis. So those patients with dysregulated host response are going to have an increase in the activation of the coagulation with DIC and coagulopathy because of consumption, and excess of inflammatory biomarkers, release of nitric oxide in the endothelial cells with microvascular dysfunction, capillary leak, interstitial edema, vasodilatation, decrease in cardiac contractility, and at the end, decrease in oxygen delivery, together with decrease in oxygen consumption and dysfunction of the organs. On the other side, some patients could have an increase in the anti-inflammatory biomarkers or anti-inflammatory mediators with an immunoparalysis. The consequence of that is that some patients are going to have early deaths because this excess of inflammation. Some of them are able to survive, or most of them are able to survive, but others are going to die in the late phase because the immunoparalysis. Those patients are going to have viral reactivation, CMV reactivation, or nosocomial infection, very prone to have nosocomial infections like catheter-related bacteremia or nosocomial pneumonia. So there are several opportunities here to treat those patients, especially those patients with potential early death because an excess of pro-inflammatory mediators. In those patients with sepsis, we see this systemic and local inflammatory response, but in most of the cases we see other phenomena together with this systemic inflammatory response. We see more or less bacteremia, and we see an increase in endotoxin concentration in those patients. So we have inflammation, we have endotoxemia, we have bacteremia with high bacterial load in those patients with gram-negative sepsis. The consequence of that, or the impact of that, is that this endotoxinemia, these inflammatory mediators, is going to have an impact in each single organ. In the brain, the consequences are going to be altered mentations, delirium, etc. In the lung, it's going to be RDS. In the kidneys, it's going to be acute kidney injury, etc. And that is what I'm going to discuss in the next slides. Endotoxin alone, as you know, is able to produce a sepsis-like syndrome. This is an example of an auto-injection of a high dose of endotoxin in a laboratory technician many years ago, and the consequence was fever, increasing heart rate, leukocytosis, and activation of coagulation with DIC. And this phenomena has been repeated thousands of times in healthy volunteers and in animal models for reproducing sepsis. In observational studies, the higher the concentration of endotoxin, the higher is the mortality, and this has a good correlation with the severity scores. If we look to the specific organs, I'm going to start with the microcirculation. The injection to these animals of endotoxin, the consequence is adhesion of leukocytes to the microcirculation. This provokes a stop in the microcirculation, or a reduced flow or an altered flow that at the end decrease the availability of oxygen to the cells. This can be blocked, this sticking of the leukocytes to the endothelium can be blocked using inhibitors of toll-like receptor 4. So this is how it can be proved that there is a direct effect of endotoxin in this alteration of the microcirculation we can see in sepsis. So this adhesion could be completely blocked by these inhibitors of toll-like receptor 4. So as I said, there is a decrease in the availability of oxygen to the cells, but also inside the cells, the mitochondria, because of the systemic inflammation, have an impaired metabolism of oxygen, so they are less able to use the oxygen to produce energy. So they have less oxygen, they are less able to use the oxygen to produce energy. So at the end is a metabolic failure or a metabolic shutdown. This is important for every organ, but it's especially important for immune cells. Immune cells need energy for each immune function, including phagocytosis, etc. So these immune cells are less able to do their function. Now I'm moving to the microcirculation. This is the normal physiology. Patients usually are in this area where oxygen consumption is completely independent of oxygen delivery. However, in sepsis, you know that some patients, because they have higher metabolic needs and because they have decrease in oxygen delivery, they are more in this area where oxygen consumption is completely dependent on oxygen delivery, and those patients have dysoxia and hyperlactatemia. Why those patients have decrease in oxygen delivery? Because they are hypovolemic at the beginning, before resuscitation, because they are vasoplegic, with vasodilatation, and because most of them have septic cardiomyopathy. This septic cardiomyopathy is very frequent. It's around 60% of the patients, when you study patients at day 3, they have systolic dysfunction of the left ventricle, but 50% of them could have diastolic dysfunction of the left ventricle. And dysfunction of the right ventricle is also quite often, 30 to 50%. And some patients have combination of these three types of heart dysfunction. If we look to the cardiomyocyte, this is an old model of isolated cardiomyocytes, you can see that after the exposure of these cardiomyocytes to cytokines, there is a decrease in contractility. So these cytokines, circulating cytokines, are able to decrease myocardial contractility. Not only decrease the reasons for that decrease in myocardial contractility is because there is a decrease in the responsiveness of the cardiomyocytes to the adrenergic drugs. And also there is a cardiomyocyte injury. You can see that better in this cartoon, where the activation of the toll-like receptor 4 is able to generate cytokines at this level and is able to increase apoptosis of that cell. Mitochondria again is with an altered function, with a decrease in ATP production, and the production of peroxynitrites are provoking that the filaments of active myosin are less sensitive to calcium. And again, the beta-adrenergic receptors are downregulated. So altogether provokes this myocardial dysfunction that leads to decrease in oxygen delivery and decrease in oxygen consumption. If we move to the kidney, we know that in acute kidney injury there are two phenomena. One of them, which is related to the activation of toll-like receptor 4 and the systemic inflammation, goes with reduced renal perfusion. But on the other side, there is a direct effect of LPS in the kidney. Again, the kidney has toll-like receptor 4, and there is a direct renal inflammation because of a direct effect of LPS on the kidney. In fact, this can be prevented administering in patients in this phase 2 study bovine alkaline phosphatase. Alkaline phosphatase is able to dephosphorylate endotoxin, so it's less efficient in activating the inflammation in the kidney, and you can, and in this study, acute kidney injury could be prevented using alkaline phosphatase. In this case, it's bovine alkaline phosphatase, but it's another phase 2 study which is very nearly to be finished using recombinant alkaline phosphatase. So those patients with acute kidney injuries have a decrease in the glomerular filtration rate and tubular dysfunction. This is the key feature of those patients. And a decrease in renal blood flow is not always necessary. Dams and pumps are filtered in the glomerular, and you can have these dams and pumps inside of the tubular space, and the tubular cells in the S1 segment are able to recognize those dams and pumps, especially endotoxin, generating a paracrine signaling to tubular cells in the segments S2 and S3. If you look to the capillary, you have the typical reaction with adhesion of the leukocytes, decreasing the flow and decreased ability of oxygen for those cells, for those tubular cells. The consequence of that are that there is going to be less oxygen in the mitochondria, less ability of the mitochondria to process this oxygen and to use this oxygen, a decrease in the uptake of chloride, an increase of chloride in the tubular lumen with vasoconstriction of the afferent arteriole and decreasing the glomerular filtration rate. So again, endotoxin inflammatory mediators are playing a key role in acute kidney injury in patients with sepsis. Acute kidney injury and RDS, again, we are going to see exactly the same phenomena. We are going to have pro-inflammatory cytokines, we are going to have neutrophilic inflammation, we are going to have dysfunction of the endothelial barrier with increasing permeability. This can be shown in animal models because direct effect of LPS in the lung, or because systemic effect of LPS with models of abdominal sepsis. And the mechanism for that, I'm not going to enter again in the internal mechanism of that. The increase in the permeability of the alveoli is again because of the recognition of LPS by the toll-like receptor 4 and very complex intracellular mechanisms. I'm going to discuss a little bit about the brain dysfunction. Brain dysfunction, you know that the brain is playing a very important role in the immune system because the brain is able, using this cholinergic anti-inflammatory pathway, to downregulate the inflammatory response. So it's playing really a very important role in the immune system. Generally talking, in critical illness, but especially in sepsis, and especially in those patients who have risk factors, these systemic insults that appear in sepsis, fever, hypotension, changes in the glycemia, together with the aggressive ICU environment and the use of certain medication, especially benzodiazepines, is causing that those patients in the ICU have acute brain dysfunction. The consequence of that is delirium, as you know, or decrease in consciousness, but some of those patients have long-term sequelae, so it's important. Talking about sepsis, we should talk a little bit about sepsis-associated encephalopathy, which is a diffuse cerebral dysfunction caused by the systemic inflammation again. It's again very common. More than 50% of patients have this sepsis-associated encephalopathy, and it's associated to increased rate of morbidity, mortality, and long-term effects. In fact, the brain is playing an important role in the diagnosis of sepsis because it has been included in the Q-SOFA, and also is considered for the diagnosis of sepsis because decrease in Glasgow Coma Scale is associated with 1 or 2 points for the diagnosis of sepsis. Which is the pathophysiology of this condition? These systemic cytokines are activating the microglial cells. How they arrive to these microglial cells? They arrive because they have specific transporters, because the brain-blood barrier is altered, but sometimes are able to achieve the brain by using specific pathways which are very close to the ventricles where there is not the effect of the barrier. So this activation of the microglial is the cause of the systemic inflammation in the brain, together with a decrease in cerebral blood flow because alteration of vasoregulation and an imbalance in neurotransmitter. So endotoxin alone is able to cause neural damage in this model of isolated neurons, and the use of blockers of inflammation, in this case is blockers of the interleukin-1 beta receptors, are able to prevent in these animal models inflammation, oxidative stress, and behavior changes that are induced by sepsis. The problem with this condition is that usually it's underdiagnosed, and there are not specific tests for diagnosis. There are not specific biomarkers, not a specific image test, or not a specific functional test. But those patients with this condition are going to die more, especially if they have Glasgow Coma Score below 13, and some of the risk factors can be corrected, like hyperglycemia or hypo and hypercapnia, but not of them can be corrected. So just for closing, this effect of each single organ are not independent. In fact, there is a crosstalk between all these organs, from the brain to the lung, from the lung to the brain, and again, this crosstalk can be prevented blocking toll-like receptor 4. So again, it seems that endotoxin and inflammatory mediators, in this case, are rats that are ventilated with different ventilator modes. And when you look to the inflammation in the lung and you look to the inflammation in the brain, if you have knockout mice for toll-like receptor 4, or you are able to block toll-like receptor 4, this crosstalk between the brain and the lung can be prevented using this way. So my conclusions is that endotoxin and PAMs are triggers of the host-regulated response we see in sepsis. Endotoxin could be also recognized by parenchymal cells in many organs and have a direct effect. So this is the rationale, I think, that can justify that we use extracorporeal devices to remove endotoxin and have another immunomodulator actions. So these tools are available, and we have to wait for the clinical trials to give the adequate information that which type of patients could benefit of these therapies. Thank you for the attention.